afternoon to everyone in the room, and good morning, good evening to those of you joining us virtually from around the world as well. And welcome to this month's Think Global session. My name is Krishna Udayakumar. I'm the director of the Duke Global Health Innovation Center here at the Duke Global Health Institute, and it is my great pleasure to moderate the next hour of discussion that's focused on the understanding of the launch and scale up of vaccines. What have we learned from the experience of COVID-19, and what can we take forward to make sure that we're more effective and equitable in the way we think about the development and access of vaccines around the world. A couple of logistics points. We have an audience here in the room with us, and we also have folks joining online. We will have time for interaction, including questions. So if you're in the room, as questions come up, please feel free to raise your hand and we will come to you. If you are online, please use the Q&A function, and I promise to monitor this in addition to my Instagram feed. So we'll make sure we get to your questions along the way. This session is being recorded and is on the record. So COVID-19, we've just lived through several years of once in a lifetime pandemic. And what we saw really created lots of tension in terms of how we think about different facts together. One, we saw tremendous scientific breakthroughs. We saw the development of new vaccines in record time, and we'll hear about the evidence behind that in just a moment. We saw just last week a Nobel Prize awarded for much of the underlying technology and mRNA vaccines that allowed many of these vaccines to come to fruition so quickly. We saw enormous upscaling of manufacturing in record time. We saw more than doubling of the number of vaccines ever produced in a year happening quickly in response to the pandemic. And if you look at the uptake of vaccines, whether it's in high income or low and middle income countries, it happened more quickly than ever before in history for a new vaccine to be introduced. And at the same time, we saw enormous global inequities play out where high income countries for almost a year had almost exclusive access to new tools that were life-saving, while many low and lower middle income countries continued to struggle with a response to a global pandemic. And how we understand what happened from an end-to-end perspective, research and development, manufacturing, introduction, scale up, will allow us to take some of these lessons to heart and be better at everything that we do going forward. And in order for us to have that conversation, I am thrilled that we've got experts from around the world joining us. First to my left is Wenhui Mao, who is the Assistant Director for Programs and Research at the Duke Global Health Innovation Center here at the Global Health Institute. We also have joining us virtually three of our colleagues. One is Ian Thornton, who's a Senior Program Officer for Vaccine Access at the Bill and Melinda Gates Foundation. Secondly, we've got Imran Raza Mirza, who's the Global Lead for COVID-19 programs and a health specialist who has been supporting the ACT Accelerator as well as COVAX with UNICEF. And third, we have our colleague Chizoba Wanodi, who's an associate scientist in the Global Disease Epidemiology and Control Group at the International Vaccine Access Center at the Johns Hopkins University. So we've got experts from multiple sectors from representing work that's happened all over the world that are going to allow us to really think about how we came to be where we are, how many of us have had 5 or 6 shots now of COVID-19 vaccine, while many in low and middle income countries have 0, and what we do going forward. So to get us started, I'm going to turn this over to Wenhui to talk us through the research that she has been leading and a publication that just came out from our group that takes a look at this particular topic.
Thank you, Krishna, and thank you everyone for joining us. So I will just make a short presentation, set the scene, so that our excellent panelists can share more real experiences with us. Before we dive into the COVID-19 and other vaccines, I just use this flowchart to illustrate the pathway a vaccine might need to go through before it is ready to use. Just a note that the real process could be much more complicated and not necessary to be this linear process. And this framework is adapted from our launch and scale speedometer program, which collect evidence and generate insights to accelerate the launch and scale up of health interventions globally. You can check more information on our website. Referring to this framework, we define the R&D stage as the time from ideation to first regulatory approval. And then launch is the stage outside of the research setting. It is a time from the first regulatory approval to the first introduction, commercialize, or procurement of the vaccine within any low and middle income countries. And lastly is the scale-up stage. It is a time from the first launch to reach at least 20% of the target population. This 20% coverage is relatively low, but we currently use it here for its availability of data. So we already know that COVID-19 vaccine have made very rapid progress, and here is some initial evidence. Among the 10 COVID-19 vaccines and here, the median time for R&D was less than a year. It's the fastest ever in human history. And the launch stage was seamless. Maybe we should measure it in days or months rather than in years because it's just so short. And the 5 out of the 10 COVID-19 vaccines listed here reached 20% of target population in about or less than 1 year. And thanks to these vaccines and other efforts, our world is gradually recovering from this pandemic. However, you may wonder, what about other vaccines? So, well, in contrast, it could be a very, very long journey for most of other vaccines. You see on this table, on average, non-COVID-19 vaccine took over 10 times or even longer for each stage than the COVID-19 vaccines. And 20 years seem to be a normal range for non-COVID-19 vaccines to reach to their target population. And for some vaccines, it could take like 50 years. So imagine if we could reduce this timeline, even just by 1 or 2 years, it could prevent lots of people, protect lots of people from the vaccine preventable diseases and also save lives. While lots of innovative practice have been applied to promote the COVID-19 vaccine, we focus on those lessons that could also benefit other vaccines. To replicate the rapid R&D process of the COVID-19 vaccine, the future vaccine R&D should capitalize on public and private knowledge sharing partnership to promote the technology innovation. And it seems like establishing the regional clinical trial and the data sharing network could also optimize the clinical trial efficiency. This could also promote the equity of clinical evidence by including population from different regions. And in the future, the application of AI and data science in the selecting candidates and deep learning on the clinical trial data may also save time in R&D. And we also see the mRNA vaccine is a game changer for the pandemic. But before the technology is put into use, decades of research has already been conducted. And to support such cutting-edge innovation, certain funding mechanism is needed to support this research. And to accelerate the launch timeline, future efforts to bring safe and effective vaccine to the market should strengthen the WHO pre-qualification and emergency use listing program. These programs have been widely used to determine which vaccines are safe and to procure and distribute by many like global actors such as COVAX, Global Fund, and also many national actors. Therefore, it is essential to enhance these programs to serve as robust and transparent regulatory system for those countries and global actors. Meanwhile, low and middle income countries also need stronger regulatory and the manufacturer capacity to ensure the self-sufficient of vaccines. Coordinated investment to build regional regulatory bodies and strengthen the national regulatory bodies can accelerate approval, thereby expediting the access to the vaccine in the future. And during this pandemic, COVAX has distributed over 1.8 million vaccines in low and middle income countries. Despite these contributions, there are concerns around the equity and the low efficiency, especially in the delivery in many low-income countries. And the Global Procurement and the Delivery Alliance could do better by including low-income countries in the decision-making process so that these countries can be better prepared for their supply chain and delivery system. The pandemic also revealed inefficiencies in vaccine manufacture, distribution, delivery, and demand generation. And efforts to accelerate the scale-up of vaccine should include creating the regional pooled procurement mechanisms among the low and middle-income countries to increase their procurement power and get better deals for these countries. And it is also important to address the vaccine hesitancy. There should be open, transparent, and clear communication through trusted outlets to build public trust, combat misinformation, and promote vaccine uptake. And lastly, global, regional, and national stakeholders should also take the end-to-end approach instead of just focusing on one specific area. Better coordination among different stages could improve the efficiency and shorten the total timeline to make vaccine accessible by everyone. So let me just pause here and invite our panelists for the rest.
Fantastic. Thank you so much for walking us through quite quickly a tremendous amount of research and data that you have led the development of. I think that sets the stage well, because this really looked across the board, as you saw, end to end from that speedometer framework, and really looking at particularly opportunities to continue to improve, whether it's around research and development, the launch of these and other products, as well as the actual scale up and reaching the last mile. And to delve deeper into each of those, let me first bring in Ian to this conversation. Ian, the Gates Foundation, you've been leading a lot of work as you start to think about how to create markets here in a place where markets don't really work. How do we think about market shaping, the ability to procure at scale as a way to enable access? Let me turn the floor over to you to share some thoughts.
Fab. Thanks, Krishna, Wenhui, for that great sort of run through of the sort of the big picture. Yeah, I'm going to focus on sort of market shaping, procurement, and supply, and drawing on experience both in the vaccine access team where I am at Gates, but also from UNICEF, where I actually spent most of the pandemic looking at the kind of global markets group, which was trying to coordinate and steer all of the kind of market related information on COVID-19 vaccines. The following kind of 5 lessons are definitely my personal experience. They're not a kind of fully sanctioned either Gates or UNICEF perspective. There have been something 30, 35, maybe more lessons learned exercises, and they really vary in scope and depth, and quite frankly, to what extent they're actually true versus a kind of whitewashing of what happened. So this is going to be kind of my take, my sort of 5. It's not a comprehensive list, but I'm hoping there's some things in here that spark some discussion. So first, for a true pandemic, so for a COVID-19 rather than for a Lassa or Nipah, you need the whole suite of supply tools. You need the push, the pool procurement, the tech transfer, the regional manufacturing, and the donations. Now, that sounds really obvious when you say it, but that wasn't how the COVID-19 pandemic played out. There was a very large amount of push funding. There was a lot of pool funding in the kind of terms of advanced purchase agreements that were put down for COVID-19 vaccines. And then we got into kind of a lot of processing of donations through COVAX and bilaterally. But there wasn't anything really on regional manufacturing, and there was very little on tech transfer. And those were sort of choices that were never quite made. They just sort of happened in terms of the way the international community's response was sort of structured. And so, you know, tech transfer, I think, was a really big sort of opportunity that was kind of missed. And as everyone knows, we ended up having a huge amount of oversupply of COVID-19 vaccines, and that was primarily because of the incredibly high R&D success rate. But if that hadn't been true, and we'd actually had many fewer vaccines coming to market, we would have needed to reach scale with fewer products. And the way that you would do that would have been through a whole load of tech transfers. And so I think there's a really interesting lesson learned around what it is you need to put in place now, including regional manufacturing, regulatory strengthening, etc., to be able to kind of open your set of supply options for the next pandemic. Because one of my fears is that the way the kind of debate and discussion is going at the moment is that we're kind of staying in pretty much the same paradigm of essentially doing advanced purchase agreements, so big deals. But fundamentally, that doesn't actually fundamentally change your supply options in a particularly substantial way. So for a true pandemic, you need to throw the kitchen sink at it. That's the first. The second, I would say, is that pooled procurement is important, but frankly, it can only do so much in the face of nationally led responses. And I think the design of COVAX and the Act A kind of umbrella under which COVAX sits was perhaps a little optimistic, perhaps a little naive. You know, the time the US had a president who was very, very explicitly putting America first. And so the idea that people would kind of buy into this sort of global kind of pooling mechanism was perhaps a little naive. You know, I think about this from a sort of domestic politics type lens, that you can lose an election for kind of your own national COVID-19 response, but you don't really lose elections for the global responses. And so pool procurement is important. It's a fundamental premise of the kind of Gavi UNICEF model. It's about buying power. But fundamentally, even pool procurement for LMICs as a whole is going to face challenges relative to high-income countries with just much bigger budgets and much greater willingness to pay. So that's two. Pool procurement is a start, but it's not everything. Number three, early money is useful, but not a panacea. And so again, in the kind of discussion that's happened a lot post the kind of tail end of the COVID-19 response, there's been discussions about putting around zero-day funding and all of these kinds of things to enable people to put down much bigger sort of deals earlier, and fundamentally to try and compete with the kind of high-income country buyers. Again, I have some concerns about this. You know, at the start of a pandemic, it's a really uncertain kind of environment. The big pharma have very high supplier power to think about the kind of Porter's, you know, 5 forces of markets, those kind of basics. And fundamentally, there is likely to be someone who is willing to put down more money on worse terms than the international community can afford. Leave aside the fact the international community is a partnership and is an international community, and so tends to work a bit slower, a bit more bureaucratic. I just don't see being able to go toe-to-toe on deals with the Americas, the Chinas, the EUs, you know, the Canadians, for example. I just don't see that as being a kind of sensible strategy to go and do this all again. And so I think the discussion at the moment has sort of, the way I've seen it, it's been sort of African vaccine manufacturing, it's been the pandemic treaty, and it's been getting big early money. And I personally don't see the getting big early money as being worth the kind of amount of bandwidth and airtime that it's been getting. So that's three. Early money is useful, but not a panacea. Fourth, I would say, don't forget delivery. And one of the real challenges early on when COVAX was really struggling for supply with the export bans and all of those issues we kind of know and understand well, was our communication with countries and how we were kind of supporting them to gear up for delivery and delivery at scale, but we didn't know when we had supply. And so there was this sort of real stop-start kind of, we think we might have some supply, but then we didn't, then it got pushed back, etc. And it made it incredibly difficult for the countries that we were working with and trying to serve to be able to fund, to plan for, to roll out delivery. Plus the fact that the way the allocation mechanism worked was around trying to get equal coverage across countries, And so there were lots of countries who were being encouraged, nudged, to take a variety of different products from a variety of different sources to try and patch together this coverage. And so you had these very challenging environments with different products, different schedules, different policy guidances, different cold chain requirements, some coming in bilaterally, some coming in from COVAX. And actually the supply landscape and the delivery landscape for a lot of the LMICs was a hell of a lot harder than what we faced in the UK and US. And so this piece around, we were so focused, I think, on our own supply challenges in the international community that we didn't do as good a job as we could have done on supporting delivery, funding delivery. And I think some of the other panelists will probably say a lot more on that. And then the fifth one is around being prepared to truly flex your model. And it's really hard to look back and know what was kind of bad strategy versus what was good strategy in a really uncertain environment. But there are some elements of the response where I don't think we flexed fast enough. So as soon as the majority of the R&D risk had passed, we knew there was going to be this impending wall of supply. And so we knew that actually donations were going to play a much bigger role in supply than anyone had thought they would at the start of the pandemic. And I don't think we necessarily flexed fast enough to become a good enough kind of donations clearinghouse. And no one wanted to be a donations clearinghouse. That wasn't kind of what the mechanism was originally set out to do. But it could have been possible to flex earlier and become a bigger and better donations clearinghouse as a sort of suboptimal but still okay mechanism, and really kind of optimize within that, rather than some of the kind of choices that were made that were around continuing to fundraise, continuing to put down deals. And so I think there is something about the scale of the pandemic, the true kind of really fast moving nature of it, means that you need to be able to kind of truly flex what you're doing from a kind of month-to-month basis. And this is really, really challenging against fundraising timelines, against bureaucracies, against all sorts of planning things. But it felt like, certainly for me, that we were always not always, often a few months behind the curve in terms of flexing. In terms of, say, changing booster policies and that sort of thing, rather than being able to respond very, very, very sort of quickly. So those are my five. Very happy to go into them. Would love to have a real discussion with the panel on things that they may fervently disagree with, but I'll pause there and hand back to you.
Thank you, and what a fantastic review, and great to hear those perspectives. And you're right, there have been no shortage of evaluations, official, unofficial, many of them representing the point of view of whoever's commissioned those evaluations as well. So love the way that you've organized your thoughts there, and as you say, we're going to hear about some of these issues much more. So let me bring in to this conversation our next speaker, which is going to be Imran, who currently is at UNICEF as a lead for the COVID-19 program. And of course, we know UNICEF is an incredibly meaningful and important organization that really jumped in and was part of this core of COVAX and the COVID vaccine delivery program that made a lot of difference, especially into 2022 in access for low-income countries. So Imran, let me turn it over to you to help us understand some of the lessons learned from that perspective.
Thank you, Krishna. Good morning, good afternoon, colleagues. So I think I'll go through some of the slides, but some of the points has already been addressed by Ayn and my other colleague Wenhui, so it may be some duplication also. Can we move to the next slide? Thank you. So as already seen that this COVID rollout, vaccine rollout was a mass campaign, and it was one of the faster deliveries in the history of the world, as we see. If you see other vaccines after the manufacturing and approval by the WHO pre-qualification, it took them long time to reach some of the coverage. The nearest what we see such a fastest scale up is of IPV when it was switched from the OPV to IPV for the polio eradication program in 2014, but even that took 4 or 5 years to reach that coverage. However, COVID vaccine, within the 2 years, it reached from the start till about 180 million or 13 billion people vaccinated in just 2 years period. Those mass campaigns have not easy because they have a strain on the health systems, because they took all the health workers and other resources were diverted, and it affected other essential health services, all those programs, because everyone was busy in conducting, planning, and implementing the mass campaigns. Second challenge, which came for the routine immunization program, or is normally targets under 1 children or maximum under 5 age of children. These campaigns were for the adult population, which was 3 times more than the normal target of EPI campaigns. So our routine programs in the countries, routine immunization programs, were not capable to handle such a big, huge target in such a short period of time because of the multiple reasons which I will come later on. In the end, then it was a current contest, then we have to look on the cost effectiveness and opportunity cost becoming increasingly important, that how much it will costing the campaign. So it is coming up that in future campaigns will not be sustainable, economically sustainable. We have to bring COVID-19 vaccine into the regular routine immunization programs or into the primary healthcare programs. Next slide, please. So if we see current status of the population coverage, which has been vaccinated against the COVID-19, is about 13.5 billion doses has been administered globally since the rollout in the last 2 years. 66% of the total population has completed the primary series, and 32% of the total population in the world has received the booster doses. But if you see, we still have equity issues in the low income countries and the middle income countries, especially the Africa, Eastern Mediterranean, those countries where our coverages are still low. So that is the challenge what we are facing, that how we can reach those high risk populations in those populations. And there were the different reasons that why. And one, I think, was already raised, that the developed countries, high income countries, they took all the vaccines initially, and it took a long time to reach the vaccine in the low income countries, plus the funding issues and the health system issues, that they were not, even when they had a vaccine, they were not been capable of implementing those, giving the vaccines to the populations. Next slide, please. For this year only, we know that emergency is over. It was declared over pandemic. However, the risk is not gone. Risk is still there. Even only in 2023, in the last 10 months, we have more than 2.3 million cases with around 71,000 deaths because of the COVID-19. And majority of the deaths are in the elderly people, 65 or plus. So that is why we are focusing, that still the risk is there and the high risk populations are at risk. So we need to reach them through our regular mechanisms. Next slide, please. So next slide, please. So I will now go through some of the challenges which we saw. I'm only presenting a few of them, but there were much more in the countries. And one was, during the pandemic, it was an unprecedented level of political support was required. Managing different engagement, political leaders, multiple forums, multiple platforms, governance mechanisms, nationalism, what has been already mentioned by the Thornton, and regional, global, again, politics, and then aligning political support with the action that we make sure. We saw that even in some of the countries, vaccine was given, but there was no high-level political support available, and doses were expired. At that time, they were not used. So that was a major challenge for us to bring every political support in the country for the scale-up of those vaccines. Then, majority of the low-income countries has a limited resources. So having those massive scale-up speed and intensity was like pushing health workers and the systems in the countries to scale up. And that was not easy because that was a major challenge that they have a limited resources, human resources, and other things. Third another one is we were learning or building while we were doing. We were learning as the pandemic was ongoing, what are the needs are there and the pressure. So it was not that something was already known. So every day we have to learn something new. We have to change our plans. The countries has to change their plans, and that was the one. Second thing was a coordination with the different partners, and I think Ayn has already mentioned support funding. Because of the pandemic and there was a required needs of the immediate funding, which was not available in the countries. So the needs were changing as the pandemic was going on. So that was another challenge for us to provide operational funding to the countries so they can scale up the vaccines. Early commercial agreements with the manufacturers. This is what happened that was already, I think, raised by Ayn also as his challenge, that there was a higher income countries has a competitive advantage. There were countries, developed countries, who even took 5 doses per of their target population, while the low income countries has no dose to be given. So majority of those high income countries, they took initial because they have the funds, they have the capabilities of manufacturing. So they took all the vaccines initially, and that was a challenge how we can do that one. Next slide, please. Second is rapid success establishment dose sharing. And also this was result of that one because some of those countries took most of the doses, and when they were not able to utilize, and because the doses were of the short expiry, they started giving the donations. So I think that was linked with that one, that if in future we have some proper mechanisms of pool funding, and as Ayn also mentioned, something like a pandemic treaty, we can address those donation problems, because not only we were trying to provide the vaccines from the manufacturers, which was committed to the COVAX, suddenly the donations start coming up, and some of the donations were the bilateral donations. And not only with the donations, some of the countries has multiple 4 or 5 types of different products in the country, given by them, some by the donations, but some by the COVAX mechanisms. And all those products need different kind of cold chain, different kind of syringes, and different kind of strategies to be delivered. So that was a major complication for the countries, how they can plan something for the different products and those things. Then the SAGE came in to prioritize the roadmaps that how they can be accessible to make sure that higher risk populations should be reached, because during these campaigns, majority of the adult population was reached, but we were sure that high risk populations were not covered because people were looking on the numbers, but not there were any tailored strategies to reach those high risk populations. When the vaccine was arrived and we were start giving, there was a large scale assessment for the country readiness. And that was also a confusion that everyone came with their own assessment tools and those things, and it was a leading confusion and needs in the countries that how they can do the assessments and how they can do a proper planning. Another challenge was increasing cold chain capacity in the countries with this huge deliveries of the vaccines, and challenges were shipping installment equipment in a limited time frame, because to scale up the rollout of the vaccines, they need the cold chain. And that was, and one of the major challenge was for one of the product was giving the ultra cold chain. Ultra cold chain was never given to keep the temperature of the vaccine at -80 degrees. It was not easy. And the major challenge we face is delivery of those ultra cold chain, because initially, because of the blockades, the flights, they were not taking. Second thing, because of the special gas in the ultra cold chain, the IATA and some of the commercial flights refused to carry this ultra cold chain to the countries. So it means that what we have to do is, in many places, that we have to take off the gas, remove the gas from the equipment, transport the equipment to the Africa, and then refill that equipment with the gas there, refrigerant gas. So that was another challenge because of the disruption of the flights and the special equipment to move in, and then installation of that ultra coach in those countries. Next one was the technical guidance to prepare for that one, because as the new products were coming up, pandemic was ongoing. It was not, there were a lot of unknowns. So whether and we were not sure even whether the product which is coming in line will be qualified or will get the EUL not, what the cold chain profile will be required for that one. And so that was, it was such a frequent, rapidly updates were coming for each and every product. And that was giving a challenge for the countries, for the vaccinators and the health workers, that how they have to keep up to date on the recent updates on the what the new products is coming on. Next slide, please. Then, as I mentioned, the countries, it was a rapid scale up, and that was a limited mechanism was available in the country for the human resources, especially at the subnational level. Countries were used to for the, like as I mentioned, the routine immunization program is used to for the under 1 children, which is about 20% of the total population in the country's maximum. Here, it was adult population, which is about to reach the 60-70% of the population. So huge amount of human resources were required. They need the trainings, and then not training, just giving the vaccine, trainings how to handle the different products of vaccines which are available in the countries. So that was another nightmare for the countries, how we can train and make those human resources available. I already mentioned before on the, because initially there was a global shutdown of the transport logistics. There were very limited transport was available and limited commercial for the sea transport and the commercial supply. So that was another challenge to transport the vaccine in the countries. We are talking about only about vaccines, like 13 billion doses are giving, or COVAX has given nearly 2 billion doses. Vaccine needs the syringes and other supplies. That was another challenge, logistical, because some of the products needs a specific, non-traditional injection devices. So it was not a regular syringe to be used for all kind of products. So procurement of those ones and delivery of the ones, vaccine we can take from the commercial flights or from the chartered planes. However, the syringes take a lot of space. So it was a challenge how we can transport syringes in the countries to handle those syringes. And the syringes has to arrive before the vaccine arrive, because some of the vaccine, because it was just coming through the EUL and from the manufacturer, has a very short shelf life, which means that it has to be consumed in the country in that limited period of time. And those the syringes and all those supplies should be available there. So that was another challenge for the countries, not only for us to deliver to the countries, but within the countries to deliver at the subnational level along with the vaccines. There was another challenge of the engagement with the private sector, which was initially not there, and then limited capacity we have in the private sector in the cross the regions. So bringing those private sector for end-to-end and different things was also a challenge in many countries, that the ministries cannot handle those things. So they needed private sector, but there was no mechanisms, and there was not so much even available private sector was available in those many of the countries. I already talked about the technical guidance, which was unknown on that one. Next slide, please.
Imran, maybe one more minute. Come back to
yes.
Fantastic learnings. We'll come back to them in the conversation as well.
Sure. So on the learnings ones, what we learned from that one is that we need a coordinated operational delivery support, should be future response and activity, including political advocacy and no regret funding. New ways of working used during the COVID-19 for the response, integration, and recovery. We also face a humanitarian pandemic response, the country, especially in conflict or areas where there's no stated government. There was a challenge that, which was a requirement of the manufacturer for INL and funding, how it can be given. We need to invest strong in the primary health care and community health system, so we can have a human resources available for the future pandemic. And we need to support the regional manufacturing of vaccines and other medical to improve equitable access to the pandemic response. So that are the main key learnings during this one. I think that was my last slide. Thank you. Over to you, Krishna.
Thank you so much. And wonderful learnings here of all of the challenges along the way, many of which we've chosen to forget about as we've moved on as we can. But fantastic to be able to look at there. And as we think about what we are continuing to build upon, tremendous scientific progress, incredible amount of collaboration that had to happen in real time without an underlying structure to make it happen. Things shifting by the day and people trying to move along the way. And then as we heard, once we solve the challenge of how do you manufacture billions of doses of new vaccine and get it to countries, it's even harder to get from vaccines to vaccinations. So how do we turn a vaccine into vaccination with shots in arms? And that becomes more and more complex the further away from central infrastructure that you get. So let me bring into this conversation Chizoba as well. Your team at IVAC has led a lot of work to try to understand how to make this possible, certainly with COVID-19, but other vaccines as well. And we've had the pleasure of collaborating on a rapid systematic review to look at some of the vaccination implementation lessons learned. Chizoba, over to you to give us some of your observations and insights as well.
Thank you so much, Krishna, for inviting me. As you know, this is work that we did together with WHO at a time when there was need for information to provide technical guidance to the countries. So we were fortunate to work together on this. Next slide, please. It hasn't moved for me.
Excellent.
Oh, should I share my slides? Okay. Well, this is just to acknowledge that this work was done with the support of USAID, WHO, and the COVID gap. Next slide, please. Next slide, please. Thank you. So the objective of the review, Krishna, thanks for establishing the background. So this rapid review was really done to describe the different types of service delivery models. As we said, we have to turn vaccines into vaccination. So how did countries get their populations vaccinated? We also wanted to describe the adaptations that were made to integrate services to deliver vaccines. And then we wanted to synthesize best practices and lessons learned. Next slide, please. So this just to show that we took the standard systematic literature review processes under a compressed time period. Next slide. Next slide. Right, thank you. So when we did the literature review, this was way back almost a year ago, we found that most of the papers that met our inclusion criteria were largely from high-income countries. So we were able to synthesize the first 25 papers for the rapid review. And you can see here that majority of the studies were done in 2002, that's when the reports came out. So it tells you pretty much what happened or what the service delivery approaches were at the beginning of the epidemic when the vaccine rollout commenced. Next slide. We found three major service delivery models for vaccines: mass vaccinations, mobile vaccinations, and fixed dose vaccinations. So for mass vaccination, it was really a fit for purpose approach to push out high volume, high speed vaccination activities. And then typically these were conducted in non-health sectors. So it could be in a stadium that they set out vaccination activities. And the key here was speed. And most of it was done at the early part of the response, to the pandemic with vaccination. There were also mobile vaccinations. And what brings out the mobile vaccination, or what makes it stand out, is that the vaccination came to you, or it came to the communities. And so it was brought closer to the communities, particularly targeting special populations that would otherwise be underserved or would be socially marginalized. Then we had the fixed dose vaccinations. These were vaccinations that happened in purpose-built facilities. For the most part, it will be clinics, it will be vaccination clinics, it will be secondary facilities, primary healthcare facilities. And then there were also some adaptations that were made to restructure other health centers to provide vaccination services. So these were the major models of delivery that we saw in the literature. Next slide. Now, we also wanted to really unpack the models a little bit. So for mass vaccinations, we found that there were about 5 different functional steps that needed to be accounted for if you wanted your mass vaccination to succeed, particularly during the early part of the response, when vaccines were scarce, there was high demand, and then we needed to prioritize high-risk groups. So appointments and mobilization became important. So it was important to have appointments so that you could restrict the early adopters or the early beneficiaries to the highest risk groups. This may not necessarily happen under normal circumstances. And then with the appointments, you had registration and screening. So these sites had to set out space for registration and screening to ensure that they were taking the highest risk clients. And then because of the risk of earlier on, there were concerns about anaphylaxis and some risk, particularly with, I think it was the AstraZeneca vaccine. So there was history taking that was accounted for. So the mass vaccination sites had to make space for that. And then, of course, you had the vaccination. And then after vaccination, you have an observation area that was set out. This is not also typical in your usual vaccination program, routine vaccination program. Next slide. So for the mobile vaccination clinics, there were 3 key things that needed to be in place for that to be successful. So, of course, you had to have the vehicles, the mobile vehicles, to reach the communities that are targeted. But you don't just go to the communities without sensitizing and mobilizing the community. So this proved to be a very important aspect of the success of mobile vaccination clinics. So you had to put in place community mobilization as a start to let them know that services are coming around. And then, of course, the appointment and registration system that was linked to the need to screen and prioritize the population and the clients. And then, of course, you have your vaccination strategies. Next slide. Then for fixed dose vaccination, what we saw from the literature review was that this was actually the model that required the least amount of special adaptation, because as we said, they are purpose-built. So these are vaccination clinics. But for the rollout of the COVID vaccine, it was important to really ramp up demand generation so that clients could come to the fixed sites. Recall that there was a lot of hesitancy around COVID vaccination, and that was driven by misinformation. So information, education, and communication campaigns played a very important role in getting people to come to the vaccination sites, fixed dose vaccination sites. Next slide. And then here we have a summary of the challenges and potential solutions for the delivery model. So first of all, for the mobilizing and pre-vaccination for mass vaccination sites, we see that the difficulty in prioritizing patients based on risk could be alleviated if we had a database of potential clients with their history. So as soon as they come, they could be flagged. The ones that are high risk could be flagged and then taken for vaccination. Another solution we found to the issues around barriers that were posed by having to have an appointment, especially for vulnerable populations, was really to open it up for walk-ins. So you could tell that towards the middle part of the pandemic, there were no longer needs for appointments, and so that was what was done. And then we also had cultural barriers, language barriers that were now mitigated by having multilingual clients. So at the end of the day, there were several myths and misconceptions that were addressed through IEC materials. So I think I will stop here. I'll stop here and just say that the three things we saw were mass vaccination, mobile vaccination, and fixed dose vaccination. And there were challenges and potential solutions that were adduced. Thank you very much.
Thank you so much, Raza. Great to see that early work. And of course, we're thrilled that we're going to continue to share and generate and share these lessons learned over the coming months and years together. And as you mentioned, along with the World Health Organization and their extended program on immunization. There's so much rich content here. We've got lots of questions coming in online. I've written down at least 20 in my own scribble that I can barely read. And I'm sure we've got, so let me see a show of hands who wants to come in with questions. We've got about 10 minutes. So we're not going to get through everything, but we will try as much as we can. Chris, let me come to you to start.
Oh, thank you. First of all, thanks to everybody. I think very compelling, and these are still lessons we're all trying to absorb as quickly as we can. But I want to just note that, of course, all COVID vaccines are not created equal. There was a great deal of variety, and particularly vis-a-vis efficacy. So, of course, the Sputnik vaccine, which you had up there, we still don't know the efficacy because they licensed it without doing an efficacy trial. So we'll never know if that vaccine worked. The early Chinese vaccines had 51% efficacy, right? But only against the Wuhan parent strain, and then it fell steadily as the variants came along to under 20%. So really almost not meeting the criteria to be in the field. And if you look across particularly low and middle income countries, they had such an array. I mean, some of them, you know, the ties started with some AstraZeneca, then they did Sinovac, then eventually they had mRNA, and very complicated. And I think what I would say is that the high efficacy vaccines turned out to really be the basis of the strongest immunization programs and the best protection, but they have the highest bar for a number of these, including tech transfer. I mean, it's easy to make the Johnson & Johnson vaccine. AstraZeneca was designed to be a global vaccine that wouldn't be a challenge. mRNA, trickier. And, you know, as one of your colleagues noted, the super cold chain was an additional problem, as is the 2 doses. So I think it's important as we look back at this and look ahead that we unpack that and not do too much merging of all the COVID vaccines, because there really are different lessons, at least for me. And I think, you know, from a science and technology perspective, what has emerged out of this is certainly that the future of mRNA is here. And we're going to see a lot more mRNA vaccines and mRNA drugs probably for other things. And so the tech transfer issues are only going to get more challenging because they are not to try at home, you know, making an mRNA vaccine.
Yeah, thank you, Chris. Fantastic point. And you're absolutely right. These are not, you know, COVID vaccine is not a COVID vaccine. They're all different. And the differentiation is starting to play out even further.
Yeah,
As you say, if you go back and look at some of the early procurement by COVAX, that didn't include the mRNA vaccine. And we had no idea which would become available, what the efficacy was, but thinking ahead, focusing on platforms that were proven made total sense. But that meant that COVAX ended up being in the back of the line for many of the mRNA vaccines because the procurement didn't happen early on. So there are so many implications that lead to the differences in equity that we saw as well. And of course, we're not done, right? So there is still vaccine development. If you look at the US with NextGen, which includes a $5 billion commitment from the US government to continue to develop new vaccines, including those that might create mucosal immunity and other things that we would want to see, pan-coronavirus vaccines that our own Human Vaccine Institute here at Duke and others are working on. So it's certainly not a static environment.
yeah.
So thank you for that point. Anybody want to jump into that or build from that comment and question here? Okay, thank you. I do want to ask, most of COVID vaccination that we saw is adult vaccination. The global infrastructure and programming that we have for vaccines around is almost exclusively for kids. Routine immunization is for kids. We're starting to think about adolescents with things like the HPV vaccine. There is no country in the world almost that has a high functioning system for routine adult immunization. As we're seeing, vaccine uptake now, especially with boosters, is close to zero. If you look across almost every low and middle income country, it's close to zero. There are people that are thinking about, from the UNICEF, the Gavi perspective and immunization, this idea of life course immunization. How do you go across and build? But this is at a time when we've seen a generational hit to routine vaccination, and we're in the midst of what's being called the great catch-up. So there's plenty of work to do to focus on kids and reaching zero-dose children and others. There are others who would say, well, this should be the backbone of primary healthcare, which also doesn't exist in most countries in a functional way. I would love to hear from you. What are your thoughts? What do we do with adult vaccination? Forget, what did we learn from COVID? And as Chizoba said, most of what worked was this idea of mass vaccination, and there were campaigns that actually weren't part of health systems. So have we learned anything that's going to make us more effective at adult vaccination going forward? And Imran, maybe I could come to you and then add others to add.
Thank you, Krishna. No, I think this is really important, and this is the challenge now we are facing, especially when the pandemic is over. And you have already mentioned, as a Gavi, WHO, UNICEF, looking from the IA 2030 life course approach, we are trying to integrate COVID-19 into the primary healthcare and routine to build up a platforms for the future adult vaccines. We know in 2 or 3 years time period, we may have a TB vaccine. So that when that vaccine will be available for the tuberculosis, how it will be given to the adult. So this is the time, but the challenge is that even to build up those systems or life course approach, lot of other resources are required. Human resources, vaccinators. You cannot just ask a vaccinator that you are giving to the children targeting, and now you start adding to the giving to the adults. Means if you compare the time to give one jab, it means that the work of that same health worker will increase at least 3 times. So means that countries will need more human resources. So that is the thing what as a global partners we start thinking. We saw the same mistake during the Ebola outbreak in 2014-15. When it was in those 3 countries, everybody was saying that we have to build up the health systems. And once the Ebola outbreak was over, nobody ever talked about the health system building in those 3 or 4 countries. We are again talking about strengthening primary healthcare, but we don't know how long we will go and how much funding will be available, especially for the low-income countries to build up those systems. Thank you.
Thank you so much. Anybody else want to jump into that? We've got a couple of minutes, so we can certainly keep going. I want to ask about an issue that came up. If we look across the board, this idea of trust in science, trust in health, trust in our institutions has been going down for a long time. It's taken a big hit in almost every country in the midst of this pandemic. So as we go forward, what are the lessons we should be learning about the science side, about the delivery side? How do we rebuild the trust and continue to work on building trust, which is going to be necessary, because I'm afraid that if we saw something now, that we would actually have less ability to take public health measures, less ability to roll out mass vaccination campaigns than we did over the last 3 to 4 years, just given where we are across every society. So any thoughts there?
Let me jump in, and it comes back to Chris's point on efficacy and product mix. Perhaps controversial, trying to start the debate here, but I feel we allowed uninformed everyday citizens to have almost too much of a perspective on a product by product level. The fact that, like, my grandparents were excited about Moderna rather than AstraZeneca, despite not knowing really anything about, R&D processes, different endpoints in clinical trials, all of this sort of stuff. And I feel that some of the trust deficit comes from the nutters who you're never going to be able to reach. That's a big chunk of the US. But some of it actually comes from kind of the more normal, more balanced citizens that actually were kind of brought into this kind of debate on an individual product level in a way that I don't think was particularly healthy. Like, when you go and get routine vaccinations for your kids, you don't know who makes the penta. You don't know who makes the HPV. You don't have a perspective on 2-valent, 4-valent, 9-valent HPV. Like, the idea that kind of normal everyday, and I'm not talking about the Trumpies here, but the idea that normal, like, everyday citizens had a perspective on the AstraZeneca product being a less good product, or J&J, or all those sorts of things, to me wasn't particularly overall helpful. And so I would actually, I mean, this is not the Gates Foundation's particular perspective, but I would personally question, like, to what extent we should go back down that route if we do find ourselves in the situation again. So just saying that to spark some discussion.
Thank you. Yeah, that's a good point of view to bring into this conversation. I've got many more questions, but unfortunately we're at the end of our time. We will continue this conversation virtually, so please do keep engaging with us. Thank you to everybody that was able to join us today. A huge thanks to all of our speakers, Wenhui, Ian, Imran, Chizoba from around the world that gave us such rich perspectives. Thanks to Caitlin Shepard, to Melissa Estrada, to Lee Wells for making sure this all happened seamlessly. And thanks to all of you for joining us in person and virtually. And please do stay engaged and make sure that we are putting into practice all of these lessons that we've been talking about today. So good morning, good afternoon, good evening, wherever you may be joining us from around the world. Thank you.
Ian, can you still hear me?
I haven't seen it.
Can you still hear me?
Oh.
Ian, are you still there?
Yeah, I wasn't sure it was a hard stop or whether it was
I
a.
wanted to answer you by saying, as an infectious disease epidemiologist, what I ended up seeing was that everyone and their mother considered themselves an infectious disease epidemiologist.
Yeah, it was wild.
And
It was
kind of
completely wild.
irritating, for those of us who actually hopefully know something of what we're
Yeah. And I don't know how you hit that balance around kind of informed citizenry, empowered decisions, etc., without getting into this, slight, like, I had people who've been like, yeah, I've taken my primary series, but I don't feel I need a booster. I'm like, what? Like, you don't go around like discussing sage guidance and be like, nah, that's not for me.
Okay.
All
right, Chief.
Sometimes too much information is also not helpful.
Yeah.
All right. Thank you all. This is fantastic.
Thank you.
Thanks all.
Thank
Great
you.
to chat.
Bye-bye.
Bye.
Bye-bye.